this is probably about my 15th or more presentation on value-based purchasing. And every one of them, I come up with some new insights that I like to share as we go through. So let's go ahead and get started. A little bit about me. As I said, I am the Senior Clinical Consultant with Blacktree Healthcare Consulting. I have been in the home health and hospice industry for about 25 years. Everything from the field nurse to the PI nurse to the clinical to the executive director of a home care and hospice agency. And we are really facing what has been promised to us for many, many years from CMS, this pay for performance. And there, you know, when it rolled out, it didn't surprise a lot of us, but it is going to be a very challenging next 5 years for the states that are in the model. Those of you that are on the call that may not be in the model right now, my gut tells me it won't be long before you are part of the program also. So let's go ahead and get started. So we're going to be looking at what value-based purchasing is. We're going to talk about how the scoring methodology will work. We're going to talk about what is the initial assessment plan your agency should be doing. How do you develop a PIP? And then we're going to end it up with a case study. So what, who cares? Why does this really matter to me? Well, the model basically is there, and it states that you and your staff will understand the model, or wait a minute, the model states, oh, if you're in the model states, oh, I'm really bad today. Do you and your staff understand the model? Do you know how to calculate the scores? If you're not in a VB state, when it rolls out, are you going to be ready? PIPs, those that are in the hospice arena, they really understand PIPs because they've been required to do them. But what exactly is a PIP, and why is it a great tool for an improvement project? So let's go ahead and roll on. So who are these 9 lucky states? Arizona, Florida, Iowa, Maryland, Massachusetts, Nebraska, North Carolina, Tennessee, and Washington State. They are the lucky ones that got chosen randomly to be part of the value-based purchasing program. So what is the goals of this program? Well, the goals basically are stated that it's a way that they can do a reward system for agencies that improve quality and at the same time penalize those with poor performance. They're hoping that this should incentivize agencies to provide better quality care with greater efficiencies. The study will show if there's potential quality and efficiency measures for appropriateness in a home health setting. And lastly, they're looking at it to be able to enhance current public reporting processes. So what is VBP? Well, in the states that are in the model, all Medicare certified home health agency must participate. It was mandatory. You didn't get to volunteer. You will compete against other providers in your state and in your cohort. Oh, what's a cohort? Well, they divided it into 2 cohorts. The first cohort is for any agency that serves less than 59 Medicare clients. They're small. Everyone else is large. So if you served greater than 60 Medicare clients in a year, you are in the large cohort. The payment adjustments will occur based on the individual state's benchmarks and thresholds. And it will also look at the agency's performance compared to the baseline year. And that baseline year was 2015. So if you're in a state of Florida, you will compete against other Florida state providers using the Florida state outcome scoring, which is totally different than the Maryland outcome performance scoring, which is different than the Nebraskas and the North Carolinas. You get how it goes. It's only focused on your state. So what are these quality measures we're talking about? Well, each one of these measures are individual rated. There are 6 process measures: care management, types and sources of assistance, flu vaccine data collection, which goes along with the flu immunization for the current flu season, pneumococcal vaccine ever received. The reason the pneumococcal vaccine was not received and drug education, all medications provided. There are 10 outcome quality measures. These sound familiar to you. Improvement in ambulation, improvement in bed transferring, improvement in bathing, and dyspnea. The discharge to community, acute care hospitalization during the 60-day period, any emergency department use without hospitalization, improvement in pain, interfering with activity, and improvement in management of oral medications. Prior functioning of ADLs and IADLs are also included. They also include our HHCAPs, and they include care of the patient, communication between the provider and the patients, specific care issues, and that is the domain that covers the pain, safety, and medications, the overall rating of the home care agency, and the willingness to recommend the agency. But we're not done there. They also gave us 3 new measures. These 3 new measures will be based on just the submitting of data. So they're not going to be benchmarked against anything. It's strictly a data collection and submission process to get your points. And there are 3 of them. First is flu vaccine coverage for any home health personnel. Now, that would include all of your employees that are on service as of October 1st of 2016, will be our first year, through April 1st of 17. Not only does it include your personnel, but any of your contracted staff. Not only does it include your employed staff or contracted staff, but also any students that may rotate through your agency. You have to collect the data on all of these. And it's not just a matter of collecting the data, saying yes, they received it, or no, they didn't. Then they want to know, where did they receive it at? And you have like 3 options. And then they want to say, if you refuse it, why did you refuse it? And there's about 3 options there. And then at the bottom, there's a comment section you can fill in. Medicare is saying that when you collect this data, you're going to fill it out in the spreadsheet, submit it up to the portal. You have to fill in every single blank. If you don't have a data point to put into that section, then you have to fill it out with a 0. So the next measure is a patient-related one, and that's on the herpes zoster or the shingles vaccine. And it kind of goes along with the one for the flu. Yes, they got it. No, they didn't. Where did they get it at? If they didn't get it, why didn't they get it? And then the comment section. And lastly is advanced care planning. Now, the advanced care planning one is also patient-related. And this one is, did they have one? Did they specify who the guardian or the other person is that can help direct care? And there's like 10 other questions that go along with the advanced care planning. Again, you have to do this on their patients, collect the data, and submit it in order to get the full points. So what happens with this information, and when do I get penalized, or when do I get the money for doing a great job? And hopefully you're in the second category. Well, basically what you're doing currently right now, and we're starting our second quarter of calendar year 16, your final scores at the end of the year, and it's going to be an average, not just what you're scored in December, will impact calendar year 18, and it's going to be a plus or a minus 3%. What you do in 17 affects 19, and then it's going to be a 5% adjustment. 18 will go to 20, and that's a 6%. 19 will impact 21, and that's a 7% adjustment. And then in the last year of the program, which is 20, it will impact the 22 calendar year at an 8%. Now, this adjustment basically means that every episode that is under Medicare in that calendar year of the adjustment, which would be 18, 19, 20, 21, or 22, will be added to or reduced based on that percentage amount. So let's figure out, how is this scoring going to work? Well, you can look at your home health compare scores. You can say, okay, I know where I stand related to the state. Or you can look at your stars and say, okay, I know how many stars I have. Well, that doesn't necessarily mean you know how you're going to be at the end of the year when it comes to value-based purchasing, because they have scoring methodologies. The first one that you need to understand is, where is your state methodology at? Where's your state benchmark and achievement threshold? So let's talk benchmark. So a benchmark is that top 10% of all the agencies that reported in your state for that outcome. What is the average score of the top 10%? That would be the benchmark. The achievement threshold, on the other hand, is that median score, or the middle point, of all the outcomes that are submitted in your state. So remember that. Achievement threshold is the middle number. Benchmark is that top 10% average. Okay, so you got that down. So now they go into scoring. You get scored on two different ways, achievement score and an improvement score. You will receive every outcome an achievement score and an improvement score. The higher the two scores is what will go on to become part of your TPS payment. So what's an achievement score? Well, achievement score basically means it takes that outcome. If your outcome score is at that benchmark, that top 10% average, then you will automatically get 10 points. Yoo-hoo, go on to the next one. If you scored below the achievement threshold, which is that middle point of all the outcomes in your state, you will get a 0. If you score somewhere between the achievement threshold, the middle point, and that top 10%, you're going to get a score between a 1 or a 9. The formula below shows you how that calculation works. And I'll run through it real quick with you. So if you take your performance score and you subtract it by your threshold, then you want to take the benchmark for your state minus the state achievement threshold, divide those two numbers, multiply it by 9, and then add 0.5 to it. And that is your number. Easy, see? So let's talk improvement score. So if your achievement score wasn't really where you wanted to be, is all hopes gone? Well, no, because now we can look at the improvement score. Again, we're going to take your score that you have this year. We're going to say, is it up in the benchmark area? If it is, woohoo, you got 10 points, go on to the next one. If you are below your baseline, so whatever your score was for the average in 2015, if you're below that score, you are going to get 0 points. If you scored higher than you did last year, but below the benchmark, you're going to get a score somewhere between a 1 and a 9. Again, I showed you the formula below it. You're going to take your agency's performance period score, meaning now, minus last year's score. Then you're going to take the state's benchmark minus your baseline score, divide that out, and then multiply by 10, and then subtract 0.5. So now whichever one of those numbers is the higher number is a number that will flow forward to your formula payment, which is what we're going to look at now. If you thought the last two screens were confusing, hold on, because this next one is really going to blow your mind. This is the formula for the adjustment in the payment. It is a multiple steps. So basically, we're going to kind of go through it quickly. It is going to take the total performance score. So your number from each one of your outcomes, now there's 21 outcomes, each of those numbers is added together, and that's your performance score. Then it's going to take your prior year aggregate payment and then multiply it by 3%. Then you want to take your TPS adjusted amounts, which was the A, your total performance score, divided by 100, and multiply it by step B. Then you're going to throw in that linear exchange function. Your final TPS adjustment payment then will be C times D. Your quality adjustment payment will be the result of E divided by B. And your final percent payment adjustment is F minus 3%. Wow is right. I'm not a math person. I have sat down step by step and done this. It took me a really long time. I don't suggest anyone doing that. If you do not know or you have not received a proposed or a projected financial statement of where you're going to be at or where you could be at, if you email me, I can help get you your company's, your CCN number is what it's based on. If you send me your CCN number, I can get this score for you. Okay, so let's go ahead and talk about, now you know where you are at, now what do I do? There's a couple things that you need to know. And of course, you've got to know where you're starting from. So what is your agency and state number for your outcomes? You know, I gave you the formula how to figure it out. Again, you know, that is going to be different for every single state. You also need to know what your 2015 average is going to be. Well, you could go in and do all this and figure out where your outcome average is. Medicare is promising us in April, knock on wood, they're going to be releasing to the agencies and the state model programs what their baseline scoring was. You know, we're getting close now to April. We're 4 days away, so we'll see what happens. But without knowing what your state benchmarks is, your baseline and your state achievement threshold, you really can't figure out in detail where you're going to be at. But you can get a good idea. If you don't have your numbers and you don't want to reach out to anyone to share with you the information that they have, then another way you can look at it is just look at your home health compare scores. Look at what your average for your state is. If you're above the average score, then you're probably going to be okay. If any of your scores, those outcomes are falling below that average outcome, then they're probably the ones that you're going to need to work on. So keep that in the back of your mind. We're going to come back to that. The next thing that you need to do after you decide and identify which one of your outcomes should be looked at, you need to evaluate your coding and OASIS accuracy. And I cannot stress this enough. You know, it is best practice out there to have an audit done on your OASIS and coding accuracy. But more importantly, you should be doing an audit for your VBP based on the discharge and the start of care OASIS. So, you know, having this done is your first step. Once you identify where your weaknesses are in your coding and OASIS, then you can develop a plan on how you're going to educate and move forward. I talked about the discharge OASIS review. And one of the important things that you need to remember is that a discharge OASIS is often done by a different person who did the admission. Why do I say that? Well, a lot of times you will start with a nurse and a therapist in the case. The nurse will end up doing, as she is required, to do the start of care OASIS. But then the nurse drops out and the therapist is left, and the therapist is going to do the discharge OASIS. Or, same scenario, the nurse goes out and does the OASIS, and then the therapist goes out and does his PT evaluation. Doing a comparison on what the PT wrote down for that evaluation based and comparing it to what the nurse wrote for her comment in her answer in her OASIS will show you if there's any kind of discrepancy going on. Now, I am a nurse by trade. I have RN after my name, and I do get a little ruffled sometimes when I hear this comment, but I know there is some truth behind it. Therapists are better at evaluating functional OASIS questions than nursing is. And I know it kills me to say that. So what do you do about that? Well, there's two things. One, use your therapy staff to help educate your nursing staff on how to assess patients for functional OASIS questions. The second thing is make sure that your nursing staff or whoever's doing, even your PT staff, when they're doing their OASIS, they're making the patient do the things that are in that OASIS. Asking a patient, can you get into the shower? Well, that's a nice question, and I'm going to tell you, yeah. But in reality, I might not be able to transfer into that tub because I can't pick my leg up to get over the rim of the tub to take a shower. You won't know that unless you ask that patient to demonstrate. So it's really important that your staff are having the patient demonstrate their ability to do what the OASIS question is asking. The other thing that I recommend is if that evaluation by that therapist is completed within the first 5 days, then the therapist really needs to contact the starter care nurse and discuss with her their findings from their OASIS, or I'm sorry, from their evaluation. The nurse, after having this discussion with the therapist, can then go back to her OASIS and determine if she answered her OASIS question correctly. Now, the thing to remember is that really this should be done before you submit your OASIS, because if not, you're going to have a lot of OASIS that you're reopening, and you don't want to do that because that will raise red flags. And you also need to realize that the nurse who initiated that OASIS has the ultimate say in whether she changes that OASIS question or not. Again, 5 days is also the rule. If that therapy visit is done on day 6, then it doesn't count and you can't change it. She can also take information from any visiting staff that goes out. So if the aide goes out and finds out something different and reports it back to her, she can use that in her consideration when she's answering her OASIS questions. The other tip that I have when it comes to OASIS accuracy is that you should be performing some type of a competency yearly, at minimum yearly, on the knowledge of your staff on OASIS. And I find this especially important for the staff that don't necessarily do OASIS on a regular basis. And I can share you an example I had with one of my value-based purchasing clients. They had an occupational therapist who did a discharge, which they're allowed to do discharge OASIS, but of course, how often does that happen? Not very often. And when I did her discharge review, I found in that chart that she answered probably 4 of the VBP questions totally wrong. And it's basically because she wasn't interpreting the question the way that it was supposed to be interpreted. You don't know these things unless you're doing a discharge review on your OASIS, or if you're doing some kind of competency testing and it is identified. So now that you've done that, you can now look at, you know your accuracy, you know where your outcomes are falling, which ones are below that achievement threshold, or which ones are not at benchmark if you're a really good agency and you're falling in between. Now you can say, okay, I need to prioritize our outcomes so I can develop our PIP. Well, how do you prioritize outcomes? Well, there's a couple of different things you can think about. The first off being, which one of your outcomes is below the achievement threshold? Flag them as #1 priority. Why do I say that? If your score is below the achievement threshold, it's an automatic 0 on the achievement threshold or an achievement scoring, unless you did better than what you did last year. Then you'll get some improvement points. Those are the ones that you really need to focus on to get them at least at that achievement threshold number. Next, I would look at which one of my outcomes, maybe if I work on this one, it may influence some of the others. And a really good example of that are any of our medication outcomes. So with our medication outcomes, it will impact the improvement in oral medication. It will impact the HH caps, which says, you know, did you instruct them on their medication side effects? That scoring will go up. And it also impacts our 5-star, because one of the 5-star questions is, did we do any medication education? So, you know, that would be a really good one to focus in on. And lastly, I would look at what one of your outcomes have you developed a PIP for in the past. If you've worked a project to improve an outcome, and it's been a year and you still haven't been able to move that outcome, it might be time to say, okay, let's just let that one go for now and move on to the next. So now that you've prioritized your outcomes, and I suggest do it high, medium, and low priority to start with, then you need to only pick 3. And why do I say 3? Well, 3 is like the magic number. If you work on more than 3 projects at a time, studies show that you have less chance of a positive outcome. It gets into overload for your staff. They can't fix everything overnight. And they're going to be getting mixed messages, and they're going to be overwhelmed with the changes. So just pick 3 to work with. So now what you need to do is develop your PIP team. So what's a PIP team? Well, a PIP team is consisted of members within your organization. You need to have people on your team that are interdisciplinary members. So you need a nurse on that team. You need a therapist on that team. You also need your QA nurse on that team. You also probably need someone else from the office, whether it be a manager, whether it be a scheduler or an office person. And most importantly, you need to have the support of senior leadership. Now, that does not mean that your executive director, chief of nursing, COO, whatever her title is, or his title is, does not mean that he has to sit in on every meeting. But what he does or she does need to do is support this PIP team and show the staff that this is an important part of the success of our organization. So why do I say you need to have one of those other members on the team? Well, I have found that one of the best people to have on that team is either the receptionist or the scheduler. And why do I say that is because they are sometimes contacted by the patient. A lot of times they may not have a whole lot of in-the-home experience. So they tend to think out of the box and come up with creative ideas. They don't overanalyze their ideas before they say them because they don't have a base into what's going on in the homes. So I always like to have one of those on the team. The other thing to think about is to have someone on your team who is a supportive, positive player. Now, I will tell you, I also like to have that person on that team who is that negative person, and you know who she is. No matter what you say, it's never going to work. Sometimes I like to refer to her as the informal leader because everybody's going to turn to her and say, ooh, what is she going to say about it? You know, if you can win that person over in your program and your PIP, how successful do you think it'll be when you roll it out with your interventions? Probably really good when they're saying, oh, Miss Nellie, negative Nellie over here is all on board with this. So what does the PIP team have to do? Well, first they need to identify the focus of the outcomes. So they got their 3 identifiers or the 3 prioritized outcomes. Now they need to say, what's going to be our goal for this? They need to state it out what the goal is. Be realistic when you're setting your goals. You know, you can't go from below achievement threshold or at achievement threshold to benchmark in 3 months. I don't think it's going to happen. But you may say, I think we can up that score by 2%, 5% in the next quarter. Just remember, anything that you're implementing today, it's going to take 60 to 90 days prior to seeing a movement in your outcome scoring because they don't get the outcomes until you discharge. So if you admit today, they may be on service for the next 60 days. So you've identified what the focus of the group is. You identified who's on your team. Now let's talk about when. You need to set up these meeting frequencies at the very beginning. You need to stress the priority for them. This is not something that you automatically cancel because of fill in the blank. And we know how that goes. This is a high priority team. without this team, you're not going to be able to get those outcomes moving. So set up your frequency up front. Set up your ground rules, and that's the why. The project charter will actually state these are the rules. Whatever you're assigned, you will have completed prior to the next meeting. You will come to the meetings prepared. You will come to the meetings ready to discuss the PIP. You will keep an open mind. You will be respectful. Whatever you want to write down as your rules is part of your charter. Your charter also is going to say, this is where the boundaries are. We are going to work on this outcome from here to here. But we're not going to talk about something else that's not specifically related to that outcome. And here's an example. Let's say we're working on improvement in ambulation. Well, you know, very quickly you can go down the road talking about PT evaluations and when do you need to bring a PT in. Totally part of what the PIP should be talking about. But where you don't want to go is into the scheduling aspect of, well, we need to make sure that we're scheduling this patient with this one and that one. That's outside the boundaries. So you want to make sure that's clear so that you don't exceed where the PIP focus is. And then lastly is the where. And basically, you need to make sure you have a room that is able to spread out, as I like to say it. I will admit it, when I'm in PIPs or working with PIP teams, the inner kindergarten teacher in me comes out. I like to use a lot of charts. I like to use a lot of colored markers, not just because they smell good. You know, I'm a visual person, so I will throw things up on the wall and we'll look at it and tear it apart. So make sure you have room to work. Okay, so we got our 5 W's. So what's next? The H, the how. So we talked about some of this already. We talked about our ground rules. Well, what about understanding the data? Well, you know, we have access to a lot of data out there. And one of the things that we need to make sure of is whatever source that we're using to base our outcomes program on, whether it be our CASPER report, whether it be one of our benchmarking companies' reports, whether it be the Home Health Compare report, which I don't recommend because that's really old data, or maybe it's something that we're getting from our EMR. Wherever that data is coming from, you need to specifically write it down of where that report is being pulled from. Because the last thing you want to do is change something in your reporting structure so all of a sudden you're getting different numbers because you changed something in the report. Once you understand where that data is coming from, you also need to understand what does it mean. So how do we compare to our achievement threshold for our state and our benchmark for our state? And then you're going to roll into the next part, which is reviewing the current processes. Now you're sitting there thinking, what does that have to do with an outcome? Well, we all have processes that we have written down, policies and procedures, maybe sometimes they're called. Let's say one of them is that on the first visit, you will complete a medication reconciliation. You will compare the discharge medication list with the list of meds or the actual, which should be pill bottles that are in the home, and identify any discrepancies and take care of it. And maybe your process goes on to say at every revisit, you will take the pill bottles that are there, compare them to the list, and also ask the patient if there's been any changes. So that's a great process. If you're doing all that, then it's pretty darn sure that your medication lists are up to date and that your patient has seen you and identified and you've talked about, and hopefully you've instructed on some side effects of the medications as you went along. But how do you know your nurses are following it? Well, you really don't unless you do a home visit with them. So one of the things that you really need to think about is how can I get out and do more home visits with my staff? Because if you don't know what's going on in that home, then it's really hard to identify if your process is broke or is it no one is following the process. So let's say they are following the process, but you're still not seeing any improvement. Well, now what? Well, now's the time to start researching some best practices. I highly recommend that you go out and look at the HHQI, website, they have a lot of best practices. Now, a lot of the best practices are written maybe for more towards the patient or more towards a general audience, not necessarily towards the home health. But we can modify those best practices in order to have them implemented within our agency. Again, let's give you another example with the medication one. Best practice out there says that patients should have a list of all their medications and carry it with them at all times. So if I go to Dr. A, to Dr. B, Dr. C, I can just pull out my list and hand it to them. Well, how can you implement that best practice within your organization? Well, maybe you can make them up a little medication guide. Maybe it's a book, maybe it's a sheet of paper, maybe it's something fancier. You know, that's the kind of stuff that you can think and make it your own. How do you adopt this best practice to make it your own? We all know about the CHF best practices. Weigh yourself every day, notify the doctor if there's a weight gain to 3 to 5 pounds, blah, blah, blah. You know, how do you implement that into your policy, your process, but also get the patient to accept it as part of their daily routine? And a lot of times that will come back to the teach-back method, which is another best practice. So a teach-back method basically says that this is what I said. Now, tell me in your own words, what did I just say? That's teach-back. Very short version of it. Also, now back to our PIP. We talked about holding members accountable for the work that's assigned. And then the other thing that you really need to know or really need to think about is how you can communicate what's going on in that PIP to the rest of the agency. That communication should happen prior to implementing any of the best practice changes or any of your other changes that you're going to do for improvement. They need to understand who is on this PIP and why this PIP is important. And then the last thing is evaluation. Evaluations are always important. They need to be ongoing. Because you've reached that goal 1 month doesn't mean you stop looking at it. You look at it time and time again. You also sometimes need to drill down to figure out what's going on why it's not improving. You are identifying these 3 prioritized outcomes. Don't take your eyes off of all the other outcomes because they still matter. You don't want to backslide on any of the others while you're focusing on the new ones. So always keeping your eyes open to your outcomes. One of the things that you will be sent after this presentation is a chart where you can track your outcomes on like a spreadsheet so that you can visually see where your changes are happening so you can trend. Trending is very important. Trending will show you if it was just a one-time dip in the numbers or is it consistently going down. Okay, so let's go ahead and look at a case study on one of the HH caps. And this is one that I was involved in many years ago. Not that many, but seems like it was. And basically, we were looking at our scoring for our special care domain on our home health compare. And the number kept going down. Now, our number didn't go down so low that we were below our average for our state, but it was concerning to me as the executive when I'm seeing this number slowly going down because I was trending it month to month and I could see it was going down and it didn't make sense to me. So I went to the PIP team and what's up with this? And they all kind of looked at me like I had 3 heads and they said, well, we're still better than the state. I said, yeah, but look, the number keeps going down. What's going on? Well, you know, they didn't have an answer. And I said, well, you know, you need to look down at the questions that are making up that domain. So when they pulled the reports and they started looking at the individual questions, lo and behold, that question one, did your nurse or someone from the agency teach you about the side effects of your medications? We were less than 20% on that. I couldn't believe it. I was shocked. So, I said to the girl, the staff that's on the PIP, I said, you got to do something to improve this. You need to work on this. So they were working on it, and I went back to the PIP team in 4 months, and there was no change. It was still about 20%. So I said, it's time to shake this team up. Let's go ahead and, let's bring in some new players. And I became intimately involved with this PIP because I really was embarrassed to have to go back to our governing board and say, this is the results. So we shook up the team, and we identified that maybe the staff needs to have some education on what the HH caps were. So we talked to the staff about the HH caps. Now, there are some rules when it comes to HH caps that you have to follow. One of them being is you can't lead the patient to answering the question in a certain way. You can't educate the patient on how to answer the question. You're not allowed to use words within the questions for the responses, the always versus the sometimes. So knowing that we had to stay within those rules, what could we do? Well, I started talking to the staff, and we did some observations with them, and we realized when they would teach the patients about their medications, they wouldn't use the word side effects. They would say, now this medicine may cause, or did you know that if you have this problem, it's probably from your medication? Well, if you're a lay person, you may not know what the word side effects mean. And if you never said to me side effects, I would probably answer never to that question too. So we implemented using the keyword, meaning this is a side effect of your medication. We put some stickers and some flyers on the charts to remind the staff and the patient to ask about side effects of medications. And we looked and we're thinking, oh, right, it's been 2 months or 3 months, and we're going to see a great improvement. Well, yeah, no. We saw about a 5% blip. And I'm thinking, wow, that really didn't solve our problem, didn't it? So back to the drawing board we did. One of the things that we identified was that at that point, the majority of our admissions were PT-only cases. Well, we all know when PT does an admission, they make a list of medications, but they don't do medication teaching. That job is done by someone within our office. One of the nurses will call the patient up, go over the medications. So we thought, maybe we have a problem there. So we kind of revised the way that our staff in the office responds to the med teaching for our PT-only clients. And now, instead of making a one phone call to make sure they understand their meds, they do some side effect teaching. They'll call back in a couple weeks prior to discharge and do another check-in for, are you sure you understand the side effects? Are you experiencing any of the side effects from the medications? Lo and behold, we thought we had a good plan. So what happened? We saw an increase. Within 6 months, that individual score, remember I told you it was at 20%, had now increased to 70%. Still under the benchmark for that individual question for the state, but what an improvement in 6 months. And within a year, they were able to reach their benchmark. So what kind of takeaway do you have from this one? Well, I like to say, 1, executive involvement is important. Why? It puts the pressure on the PIP team maybe, but it also shows the rest of the staff that this is an important issue. Don't be afraid to shake up your team every once in a while. Make sure you're thinking out of the box, and kiss it. Keep it simple. So, are you ready to get off the bench and take care of VBP in your agency? I hope you got some information out of this that you can take to your agency now and start preparing for VBP, or if you're in a VBP state, implement some of the things I said to help with your scoring. So hopefully Trip's on the other end, and we can open it up to any questions.
Absolutely. Well done, Diane. I've got 3 questions that have been queued up already. The first, which was by Rob Stoltz. asked, what percentage of OASIS do you typically review for an effective audit?
So we recommend the first time line review doing between, I do a 10% for my VBP audits. 10% is going to show me if there's a problem there or not. Now, if you're really doing your first time ever doing an assessment of your staff OASIS encoding, you might want that to be a higher percentage, but 10% is a good starting point.
Okay, excellent. Thank you. The next question, and I hope I get your name right here, Brianne or Breen Hunt asked, and this is a little bit of a question here, and I went to Auburn, you'll have to remember, so bear with me. Healthcare intelligence companies have pointed out that hospital value-based purchasing quality scores have a high level of volatility, which indicates that they may not adequately measure true underlying quality. Is this also an issue for home health value-based purchasing?
Absolutely. One of the things, I'll expound on that a little bit. One of the things that has always concerned me is that when you're looking at our OASIS as a measuring tool for our quality of care, there's so many influences to the way or the OASIS question from nurse to nurse. There's the best practice, the guidelines that are out there on what the question means, and we should be following it. But it's a judgment call. You also have, and I'm sure it's none of you on this call, ones that play the game, we'll call it. And maybe they're not being as accurate on answering that OASIS question on admission or discharge as they should be, which will alter the scores for everyone. So, yeah, there are some issues there. But it's what we have to live with.
Roger, right. Next question comes from Ms. Anderson. Says, so do we need to be collecting information about the shingles vaccine and advanced care planning now?
That goes into effect July 1st. So July 1st is when you have to start doing your collection and submitting at that point. If you do not have the spreadsheets that CMS released on the new measures, if you shoot me off an email, I can send them to you.
Roger. And the last question we have so far is, what are EMRs or other technology providers doing to help agencies collect value-based purchasing outcome data?
That's one of my other favorite questions. Every EMR is different. And I will tell you that the EMRs did not receive the new measure information from CMS as of now. If they received it, they got it from one of their agencies that gave it to them. You cannot depend on your EMR, on your new measures, to be there for you. You need to figure out now how you're going to be able to collect this information. You also need to talk to your vendor of your EMR, and you need to ask them that exact question. What can your system do for me to help me understand where I stand with my value-based purchasing program, with my needs, with my data? Does your EMR allow you to drill down in your data to identify, either at the team level or the nurse level, what the results are? If they don't, is there another way you can get to that? Can one of the other benchmarking systems do that for you? But definitely, this is the time that you really got to get to know your vendor for your EMR and put the pressure on them to help you meet the new needs that we're facing in VBP.
I gotcha. So unless there's any final questions, I'll bring us in here for a landing. And, oh, there we go. Excellent. Well, they keep coming. This is great.
I don't see them, so that's wonderful.
the question is, so do we start submitting data to the portal July 1st also? How do we even know the exact information to collect on shingles and other advanced care planning?
Okay, they did release all the different data points that you need to collect for the new measures in a spreadsheet, and I do have that. So again, if you shoot me off an email, my contact information is on the first screen, or it's Diane Link at blacktreehealthcare.com. I can send you a copy of those spreadsheets so that you can start figuring out how you're going to collect the data and submit it. And right now, they haven't even said how or what the portal's going to look like. The last call that I was on, they didn't even mention the portal. Well, they mentioned the portal, but they didn't go into detail about it.
Roger that. And also, if you weren't able to write Diane's email address down in time, obviously you could just respond, to us here at CurePort. Info@cureport.com. We'll make sure you get that as well. Also, those on the call, on the webinar today, you will get a couple handouts in your email tomorrow relative to tracking these measures for your agency, as well as an overall kind of methodology and timeline for value-based purchasing. And if me and Diane can get our grits in the bowl in time, then we may just add that spreadsheet that she mentioned as well to automatically come to you. So hopefully we can provide
grits in the bowl?
Say that again?
Grits in the bowl?
Well, I'm sorry. The Georgia in me comes out every now and then. We do have one final question. One more question. This is great.
Okay.
Ms. Nancy says that the portal has the information on it as of today through the enterprise portal. So thank you.
It is out there now. Okay, good. Thank you.
Okay. I know we're a little bit early, but I'm sure no one is going to be too upset that the meeting got done a little bit earlier on your calendar, and you can go catch up on some emails and things like that. Yes, you will get a copy of this PowerPoint tomorrow as part of the automated email that you will get. Yes, ma'am. You will get that as well, and we appreciate very much your attendance here at our first CurePort webinar. Please visit our site, www.cureport.com, to see a good idea of what we're going to be delivering now and in the near future relative to not just value-based purchasing, of course, but just general education and informational topics across the healthcare continuum. I'd also challenge you to go to our vendor corner on our website to take a look at some of the vendors we're very proud to be affiliated with at this juncture. We'd love to get some more feedback from you if you're a customer of one of those vendors. You know what? For today, I'm going to get off the shill. Y'all have given me enough of your time, but we really do appreciate it. Again, this is Trip Matthews from CurePort. Diane, thank you so much. You did a great job. I got to tell you, I'm impressed. I got to look at you in a different light now. I've known you for a while, but now I've, you actually are smart as you say you are. So it was enjoyable, dear. I appreciate it very much.
Great, and I hope it was very helpful to everyone that was listening. Good luck, everyone, and please feel free to shoot me off questions. I'd like to answer.
Have a great afternoon, everybody. Hope you'll be back for the next CurePort webinar. Have a good afternoon.